Welcome to Hypo or Hypo, Extremes of Physiology in the Anaesthetised Patient. And my main issue, or my main aim actually, is to make this really quite practical, but there's going to be a bit of physiology that we have to get through first in order to really understand why things are relevant and why we're concerned about things. So you might think, why has she included these pink animals in her slideshow? And the reason is that these are little water bears, tardigrades, that are basically indestructible and can live anywhere on the planet. Really hot, really cold environments. They can suspend their metabolism, and at the same time, they can also live basically in really, really hypoxemic conditions. They're everything that our animals are not. And anesthesia pushes our animals to quite extremes in terms of physiology, as do disease processes. And I've just put these up to remind us that we're not dealing with little indestructible things and that really we do need to be careful. So what will we cover? Basically, we're going to have a whistle-stop tour of physiology so that we've got an overview and something to refer back to. I'll look at fluid homeostasis and acid-base balance, and I know that people are probably quite put off by those concepts, but don't be worried, we'll get through it, and I'm going to try and keep it brief. And then I'm going to really focus on how to troubleshoot hyper and hypotension, hyper and hypocapnia, hypoxemia, and hypo or hyperthermia. So we've got to remember that I'm trying to make something that's incredibly complex quite simple, and even though my diagrams might look a little bit complex at times, they are very oversimplified, and just because I'm recommending a certain approach doesn't mean that that's the only approach, and it also might not work for every patient. So we're going to focus on the common problems and the common causes. And I'm going to start with looking at physiology in a nutshell. So we've got total body water, which accounts for 60% of the body weight of the animal, and the majority of that is intracellular, and 40% of that, in fact. But most of that is invisible to us, and we're not really able to quantify that fluid status at all. Then we've got the extracellular volume, which is 20% of body weight, but only 5% of body weight is intravascular, which is the component that is going to affect our cardiac output and venous return, which are basically the same thing. So cardiac output being the amount of blood that's ejected by the heart, and then the venous return is that which gets back to the heart, and they should be the same. That then permits organ perfusion, so the blood is being pumped around the body, and then we've got pulmonary gas exchange, which of course the lungs are also an organ that has blood being pumped through them. They then feed back into the bloodstream, the oxygen that they've taken up, and they remove the CO2. That then is important for tissue oxygenation, which is in turn passed on to the cells, which demonstrate some enzyme reactions that are temperature and pH specific. So it's very important that pH and body temperature are also tightly regulated. So broadly speaking, even though we deal with a range of animals from different physiological backgrounds to a certain degree, they're all mammals, and they all need a temperature of about 36.5 to 39. And outside of those, we start getting critical problems, which I'll get on to talking about. Then I've included some other cutoffs. You can see that blood pH is actually relatively wide range in pH terms anyway. And then our arterial oxygen and CO2 should be above 80 and under 45 respectively. Moving on to fluid homeostasis. So we've got this, I'm going to repeat these over and over again. We've got the cardiac output and organ perfusion, which will affect pulmonary gas exchange and therefore tissue oxygenation and thus cellular metabolism. We've got body temperature and we've got acid-base status that influence these. If we are then severely dehydrated or hypovolemic because we've hemorrhaged, then that is going to affect our cardiac output and venous return. That will then affect organ perfusion, and it also affects blood viscosity. So you're reducing the amount of fluid component in your blood, so it's going to become more viscous, so therefore thicker, and it's going to find it harder to flow through vessels and therefore achieve adequate organ perfusion. That then affects the lungs as well, because as I say before, they're an organ just the same, and that will affect gas exchange and therefore tissue oxygenation, which then affects your cellular metabolism. Another thing is that if your organ perfusion is bad and if your peripheral perfusion is poor, then your body temperature is going to suffer. So particular extremities are going to be quite cold. If you're then not using oxygen because you haven't got any delivered to you, then you're going to develop lactic acidosis, and of course a drop in pH will also affect enzyme function. So anesthesia in the cardiovascular system. Once again, we've got the interplay between the cardiovascular and the respiratory systems, the fact that body temperature and acid-base balance affect it, and now we introduce our anesthetic drug, which most of the time will cause bradycardia and therefore a reduction in cardiac output. But it can also cause vasodilation, for example, like acepromazine, or it can cause increased vascular tone like medetomidine, which will affect organ perfusion. And that will affect pulmonary gas exchange and tissue oxygenation and metabolism. And then if you have reduced vascular tone, for example, you're going to vasodilate, and that's going to mean that you can't have your compensatory or regulatory vasoconstriction to maintain body temperature, so you may become hypothermic, which also affects your cellular function. You become acidotic because you have poor tissue oxygenation, and the whole thing is a vicious cycle. In terms of hypercapnia, again, organ perfusion and pulmonary gas exchange are inextricably linked. Your metabolism much depends on it, and your acid-base status influences it. If you begin hypoventilating, you're going to have a hypercapnic situation whereby your organ perfusion pressure is going to be affected because CO2 affects vascular tone. That increases intracranial pressure because you will get vasodilation, which will then reduce cerebral perfusion pressures and therefore affect brain oxygenation. If you hypoventilate, you're also going to increase your CO2 burden, which is an acid in itself, and that causes an acidemia, which affects your cellular function. Now, acidemia is what we refer to in the blood in terms of what we can measure, and acidosis is at a cellular level. If we hypoventilate really badly, then we'll get hypoxemia as well, which will of course affect our oxidative phosphorylation, and at a cellular level, once again, we refer to that as hypoxia. Now, acid-base buffering and sort of this kind of concept puts lots of people off, but actually it's pretty straightforward. And really what it means is that you've got an open buffering system whereby carbon dioxide can be eliminated from the body from the lungs, but can also be generated by the lungs through hypoventilation, and the kidneys can excrete fixed acid, which is the non-volatile, i.e. non-CO2 acid. And the equation in green basically gets shifted to the left or the right, depending on whether or not you've got more fixed acid or more respiratory or volatile acid, respectively. So once again, you've got the cardiac output, organ perfusion, and pulmonary gas exchange triangle, which then affects the tissue oxygenation in the cells. If you introduce your anesthetic drug, it will alter the chemoreceptor threshold. So basically your brain is going to think that a higher CO2 is now the acceptable norm. It reduces the minute ventilation through reduced respiratory drive, which then results in hypercapnia. It also reduces the amount of oxygen in the blood. And carbon dioxide itself is a stimulant, so it causes sympathetic drive increases that cause tachycardia and hypertension. And although that can increase cardiac output to a certain extent, it doesn't really negate the negative impacts that it's got. The hypercapnia will then also act as a respiratory acid and therefore cause acidosis and acidemia being in the blood, and that affects the cells. And then if you've got severe hypoventilation, you get hypoxemia, which of course affects oxidative phosphorylation and then has an effect on pH. If your body temperature is below 36 degrees centigrade, you again affect various organ systems. So to recap them again, we go from cardiac output, organ perfusion to the lungs, which then affects tissue oxygenation and waste removal and therefore the cells. Body temperature and acid base are influences on this. So if you have hypothermia, you slow your conduction in cells, particularly in nervous cells, which will result in bradyarrhythmias, which reduces cardiac output, which reduces organ perfusion, but there's also increased blood viscosity. So basically the colder you get, the thicker your blood. That then reduces organ perfusion, which affects the lungs just as it does the other organs. And you also have a reduced respiratory drive, and I'll get on to why in a minute. You have a higher affinity of hemoglobin for oxygen, so your hemoglobin-oxygen dissociation curve, which I'll cover a little bit later, will be left shifted, and basically the hemoglobin is less likely to give up oxygen to the cells, which then affects tissue oxygenation, cellular function, and therefore acid-base status when you haven't got any oxygen around. And that causes acidemia. Now, this all gets a bit confusing in terms of acid-base because, as I was saying, there's a reason for reduced respiratory drive, and actually your CO2 falls. And that's because CO2 is more soluble in cold blood than it is in hot blood, which means that you actually get a relative alkalemia at the time, especially when your hypothermia isn't that bad, and that then affects cerebral perfusion and reduces cerebral blood flow. So I know it's confusing that on the one hand you can get an acidemia because you've got really bad tissue oxygenation, on the other side you can get an alkalemia because your PCO2 falls because your carbon dioxide is more soluble in blood. But really the take-home message is that you're probably going to have a mixed acid-base disorder, and that is bad. And then everything slows down, your metabolism, your immune function, etc. You produce less carbon dioxide, which again reduces how much respiratory drive you've got. You reduce your oxygen consumption, which can to a certain degree be helpful because of course everything is slowing down, but you're also not really delivering oxygen as well. And you slow your drug metabolism, so you're going to have a much slower recovery if you get cold. You're then also hypocoagulable, so animals have a higher transfusion requirement if they're cold. And because of the reduced immune function, you also have a much higher risk of post-operative infections. So anesthesia and body temperature is a little bit complex, but basically the normal body temperature that's acceptable to your body is reset to a lower level. So your body will now accept, let's say, 36 as the new norm. Anesthesia also prevents the normal regulatory mechanisms like shivering or vasoconstriction from keeping your body temperature up. So normally if you get cold, you're going to peripherally vasoconstrict and maintain your core body temperature. But if you're using drugs like acepromazine or inhalants, for example, that's going to cause vasodilation and basically diminish your ability to counteract that heat loss. You also reduce the metabolic rate, and that's generally because anesthetics are depressants. And therefore you're going to have less heat production as well as less heat retention. So really the green dog on the left is meant to show the animal when it's awake. It's got vasoconstriction, so it's keeping its core relatively warm, nice and red, and the outside is a bit cooler and green. And then we give this dog some isoflurane, for example, or acepromazine. It vasodilates, and suddenly its core is not very hot anymore, but there's much less of a difference between its periphery and its core, and that's because it's vasodilated. And then similarly, on the right-hand side, you can see a graph that shows the 3 different phases of hypothermia under anesthesia. So the initial decline is very rapid, you get vasodilation and very quick loss of heat at the beginning, and then everything starts to equilibrate a little bit, you're getting colder and colder, but your rate of heat loss is less, and then eventually it levels out. The one caveat about this is that some animals, particularly cats and also some cattle, etc., can become hyperthermic, so hot with opioids, and that's particularly bad for cats if they were hypothermic intraoperatively. So it may seem counterintuitive, but if the cat got really cold under anesthesia, you may find that when you give it an opioid post-op for analgesia, it might actually get hyperthermic. So I guess we've gone through the physiology and we know why things are bad and how basically the simplest thing can seemingly affect the entire body and all the homeostatic mechanisms. But what can we actually monitor clinically? And the answer is not very much. So all the things in grey on here, I'm going through the same flow diagram as before, you might notice, are things that we can't really monitor directly. And so we've got not very good idea of fluid status, organ perfusion, cardiac output, tissue oxygenation, and what's happening at a cellular level. We've got some idea of pulmonary gas exchange. We've got a reasonable idea of body temperature and acid-base status. And the first thing we can do is we can measure packed cell volume and total protein. So that won't give us a very global total body water estimation, but what it will do is tell us a little bit about what's going on in the intravascular space and whether or not we're losing the fluid component of plasma, basically. We can then also measure blood pressure. So this is an indirect way of ascertaining whether or not our cardiac output might be okay. But as we get onto in a minute, more than just the cardiac output affects blood pressure. Capnography has earned some brackets because it can be used as an indirect means of assessing cardiac output, assuming that your minute ventilation is the same. So if your animal is breathing at a constant rate with a constant tidal volume, the only thing that should be changing, the CO2, assuming measurement is being performed in the same way, should be your cardiac output. So if your cardiac output goes up, your end tidal CO2 should go up. If your cardiac output goes down, your CO2 should go down too. And then electrocardiography is also in brackets, because although it can tell us what electrical activity is going on in the heart, that by no means indicates that the heart is actually pumping and producing an output. Then pulse oximetry is also in brackets because really it's a piece of equipment that's very prone to poor signal noise ratios and artifacts, but it can give us an indication of the saturation of hemoglobin. But because it doesn't measure as many species of hemoglobin as a co-oximeter, it really only gives us a fairly superficial appreciation of what's going on. Then we've got arterial blood gas analysis. We can see what our CO2 and our O2 is in arterial and venous blood. And then again, capnography features there as well. Rectal and esophageal temperature actually get quite close to core temperature, so that's a reasonably good thing to do. And then we can use blood gas analysis, also venous, to look at pH status, acid base, bicarbonate, that kind of thing, and electrolyte analysis. And then capnography features in there as well because of the fact that CO2 is the main volatile acid. But you've got to remember that we can only ever really see the tip of the iceberg. So I guess you might ask yourself, if we can only see the tip of the iceberg, then how can we possibly troubleshoot what's going on? So the next slides are all aimed at helping you either understand what the cause is for some of these complications, or how you go by basically finding out what might have caused it in a step-by-step fashion. So in the top right corner, you'll generally have a black box which indicates what I consider the cutoffs are for really quite bad hypothermia or hypertension, etc. And then you'll find the flow diagram beneath. So in terms of hypertension, we're going back to physiology again. So you've got the total peripheral resistance, which is determined by vascular tone, and multiplied by the cardiac output, which is determined by heart rate and stroke volume, which is the amount that the ventricle ejects per beat, and that determines the blood pressure. Now we can count the heart rate, and we can estimate the stroke volume only, and then we can measure the blood pressure. But of course, because we're only ever estimating the stroke volume, we can never really be sure what the cardiac output really is. But then again, how important is that on the day-to-day basis in general practice? And the answer is, it's probably more important to recognize the trends. So if you use an alpha-2 agonist, such as medetomidine, that will increase your vascular tone, which will increase peripheral resistance and therefore blood pressure. But medetomidine can also cause a baroreceptor reflex, which then results in a drop in heart rate and therefore a drop in cardiac output. So just because it affects one part of the equation doesn't mean it doesn't affect the other parts in addition to having a knock-on effect on blood pressure. So it's just worth bearing in mind. Having high sympathetic tone, such as related to catecholamine release, can occur because of an inadequate plane of anesthesia, pain, or hypercapnia, and that will then increase the heart rate, the stroke volume, and the vascular tone because of wide-ranging effect on adrenergic receptors, both beta and alpha. And then we have tachyarrhythmias, which can be pathological, and the problem with them is that they can increase the heart rate, and they can cause hypertension, but because they probably reduce stroke volume, actually they can also be considered in the hypotension section. And certainly as they become worse, they're more likely to cause hypotension. So mild hypoxemia can cause a tachyarrhythmia, usually a sinus tachycardia, and then electrolyte imbalance that causes irritability of the cardiac muscle, such as hypercalcemia, can cause tachyarrhythmia as well. So the first thing you want to do is assess patient depth, consider the heart rate and the ECG, assess the respiratory rate and the capnograph, and assess electrolytes. And it's the same kind of approach for hypotension as well. So under anesthesia, as I say, assess your patient depth. If the patient depth is inadequate, then you probably need to increase your vaporizer setting or give some induction drug or maybe top up sedative because the animal is too awake and therefore is getting sympathetic stimulation, which is causing the hypertension. And then you keep assessing your patient in that circle until you've got the balance right. If you've got adequate depth of anesthesia, you need to still assess your heart rate. And if you're bradycardic, you need to work out if the animal has got an iatrogenic reason, such as medetomidine, for being hypertensive. If the answer is yes, it had medetomidine, then you should consider giving atipamezole if it's really bradycardic. If it's not that bradycardic, and that really depends on the size of the animal as to what the cutoff is there, then I would potentially ride it out and monitor the patient. If it becomes hypotensive or if the pauses between QRS complexes are too long, then I would still give medetomidine. If the answer is no, and it's hypertensive and bradycardic, then you've got to think, is there some sort of underlying pathology for this? And the most serious one and the most common one, I guess, would be raised intracranial pressure. And hopefully you'll have picked up on your clinical exam or in the animal's history whether or not it's likely to be raised intracranial pressure. But if in doubt, hypertonic saline or mannitol should be given. And it's probably safer to give them and the animal didn't need them than to miss it and the animal herniates. If the animal is bradycardic, it's still possible that it's inadequate analgesia. So although most animals respond with tachycardia and hypertension, some animals actually develop a vagal response. They are so painful, they have a baroreceptor reflex, and they become bradycardic, and it's actually worth giving additional analgesia. If the animal really suddenly vagals, then I would still give anticholinergics like atropine as well as additional analgesia. If the animal is tachycardic, then again, as I said, it could be inadequate analgesia. If the animal is also hypocapnic, i.e. it's probably panting, then it's again worth considering whether or not it's got enough analgesia on board. If it's hypercapnic, then it's probably hypoventilating, and actually the thing that's causing the tachycardia and the hypertension may well be the hypercapnia. So then you might need to consider prolonged manual ventilation. If you think the tachycardia is probably a pathological arrhythmia, such as related to hypothyroidism, then you're going to have to treat it symptomatically, for example with esmolol, or you're going to have to treat an electrolyte abnormality once you've investigated it. So basically, in summary, if you're unsure, check your patient depth again and again, and consider giving some trial analgesia. But do make sure that you rule out some life-threatening things, for example, electrolyte imbalance or cranial hypertension. So hypotension under anesthesia, the top right corner should actually read a systolic pressure of less than 90, not greater than 90. You've got, again, your total peripheral resistance, cardiac output, multiplied together to give you the blood pressure. We can measure the blood pressure, but we can estimate the heart rate, the stroke volume, and measure the heart rate. Your vascular tone now will be reduced if we're going to have a reduced blood pressure. So those are agents like acepromazine and inhalational agents, propofol, etc. Systemic inflammatory response syndrome and sepsis will cause vasodilation and therefore also a drop of blood pressure. A high vagal tone that causes bradycardia will reduce heart rate by definition, and that's often opioids, but it can also be alpha-2 agonists. Now, be aware that alpha-2 agonists cause bradycardia in two phases. So they cause an initial baroreceptor reflex where basically the heart rate drops because the blood pressure has gone so high that it's a protective mechanism to prevent ongoing hypertension. And then there's also a central mediated bradycardia which lasts longer than the first phase, and it can then result in a hypotensive phase once the peripheral vasoconstriction wears off, and that's really where we're going to see the hypotension to do with alpha-2 agonists. We can then have pathological bradyarrhythmias, for example with severe hypoxemia or electrolyte imbalance like hyperkalemia. And then hypovolemia will of course affect stroke volume. If there's nothing to pump, then the blood pressure is going to go down. So once again, assess your patient depth. It's the easiest and quickest thing to do. Assess your mucous membranes and the capillary refill time, the heart rate, the pulse quality, and auscultate the chest. look at your ECG rate and rhythm to assess for arrhythmia, and assess your electrolytes. So, assess the patient depth. If they're too deep, then you probably need to decrease your vaporizer setting. If they're okay, then assess their mucous membranes and capillary refill time. If the refill is slow and their mucous membranes are pink, they're probably vasodilated, or they might be hypovolemic. If their CRT is normal and their mucous membranes are pink, they can still be possibly vasodilated. And if they're pale, then they might be vasoconstricted or anemic. So again, there are more than one reasons why mucous membranes can change color, and it's worth taking it into account in terms of the whole animal and the context in which it's behaving. So what kind of drugs it's had, has it got a history of trauma, is there likely bleeding, etc. For all of those, it's only going to help you to assess pulse quality in addition to your mucous membranes. So if you have a good or hyperdynamic pulse, your animal's probably vasodilated, and it might be one of those SIRS or sepsis animals, or it could be one that's had acepromazine, and then you may need to give ephedrine, which is basically an adrenergic agonist that increases vasoconstriction or vascular tone, and also has some mild beta effects, so it can increase contractility. If your pulse quality is poor, then you might have to give a trial fluid bolus and see if your pulse quality improves, if your heart rate potentially comes down. Often these animals have a compensatory tachycardia. And if your animal is pale and you've already noted that it might need blood transfusion, then that is most likely the case. So next you assess the heart rate, which I've already mentioned, and the rhythm. So if it's tachycardic, once again you reassess your pulse quality again, and you might find yourself giving fluids. If it's tachycardic and you think that it might be the tachycardia that's actually causing the hypotension, then you might need to treat that symptomatically with beta blockers, for example. If your animal is bradycardic and that's causing the hypotension, then you need to work out, has it had alpha-2 agonists, in which case it probably needs atipamezole, because we're in that phase where the alpha-2 agonists are causing hypotension with a bradycardia in the absence of increased vascular tone. Or if it's an opioid, for example, and it's increased parasympathetic tone, you might need some anticholinergics like glycopyrrolate or atropine. If you don't think it's drug-related, then it's worth checking the electrolytes and treating for any abnormalities that might be present. Basically, the take-home message is, if you're not sure, you should probably start CPR with profound hypotension. So in people, they're starting to talk about profound hypotension that might need CPR with the heart still beating at a systolic of 50 or below. So it's really important, if in doubt, you should probably start compressions. Now moving on to the respiratory side of things. So I've just thought I'd summarize a day in the life of carbon dioxide, and basically I just want to follow the carbon dioxide molecule from the cell all the way to the capnograph where we detect it. So we've got our cellular metabolism. The CO2 then travels across a concentration gradient into the capillary, which then drains into the venous blood, including the pulmonary circulation, and into the pulmonary capillaries. It then crosses into the alveoli, hopefully over a negligible diffusion barrier, into the bronchioles, bronchi, trachea, out via the larynx, and then the capnograph adapter on the breathing system detects it, or well, rather sends it to the capnograph, which detects it. So hypercapnia is an end tidal of CO2 of more than 45, really, but when you're talking about permissive hypercapnia, which is what we often accept under anesthesia, we're probably above 55 to 60, and we really accept a higher CO2 because actually, to a certain degree, it maintains our cardiovascular system, and if we're having to IPPV, so provide ventilation, that can have detrimental effects that we're not necessarily wanting to have, for example, reduced venous return. So hypercapnia can be caused by hypoventilation. So the minute ventilation is determined by the respiratory rate and the tidal volume. If either one of those drops, then you're going to get reduction in minute ventilation and ultimately hypoventilation. So the most common culprit under anesthesia are our drugs, such as opioids or induction agents, but either through their chemoreceptor resetting or through muscle relaxation or both. And then there are patient factors, for example, lung disease. The lung can't physically move as much, airway obstruction, pleural space disease, atelectasis, and brainstem disease, and that's obviously reduced respiratory drive. Very rarely is hypoventilation actually severe enough to cause hypoxemia as well, so we'll cover that in a minute. Then we have impaired diffusion, which very, very rarely affects CO2 because CO2 is so incredibly soluble and small and able to cross diffusion barriers. But in severe lung disease, you could get hypercapnia. It's very rare though. Then excessive production of CO2. So this is another important one because it's potentially life-threatening. So you get increased production of CO2 from the cells in a hypermetabolic state, and I'm really thinking of malignant hypothermia, which, although it's not very common in small animals, in fact it's very, very rare, it is reported in large animals, particularly in pigs, and similar syndromes have been reported in dogs as well. So it's worth considering because it is very quickly life-threatening. Then we've got equipment issues, so these are going to be very common. Inadequate fresh gas flow for your non-rebreathing systems like the T-piece, or excessive breathing system dead space. So here I'm talking about anything that extends the patient's trachea basically beyond its nose. So that would be the Y connector on the breathing system, a humidity and moisture exchanger, a capnograph adapter, a really long endotracheal tube. Especially if the patient has a small tidal volume, that's not going to overcome that dead space. It's going to start rebreathing. If you have a circle system, then that relies on the fact that you've got one-way valves which prevent bidirectional gas flow through the system. So if one of those breaks, then you're likely to get very, very quick, very high rebreathing. And if your soda lime is exhausted, that's usually a more insidious onset, so you start to get more and more rebreathing as the soda lime changes color more and more. But do be aware that if it's been exhausted for a while and if it then gets not used and lies around, it may well change its color back to its original color and not look exhausted. So in terms of hypercapnia troubleshooting, most of the time it's going to be drug related, but it's really important that you check the equipment and the patient first because those can be really dangerous. So assess the capnograph and then give some trial breaths is basically what it consists of. First question is the patient rebreathing? So I've drawn a capnograph there where you can see that the capnograph on the second breath does not fall to zero. So there's a gap between the x-axis and the bottom of the capnograph. And then the end tidal CO2, which is denoted by the plateau, is increasing as well. So if the animal is rebreathing, then you might need to increase the fresh gas flow if you're on a non-rebreathing system like a T-piece, or change your soda lime if you're on a circle system. You then give another breath, or you continue monitoring whether or not the animal is rebreathing. And if the answer is yes, then you keep giving breaths and you assess whether or not the patient is having trouble with dead space. So basically, if your animal has got a problem with machine or circuit dead space, giving a breath is not going to overcome that. If the animal has an undesirable respiratory pattern and it's actually got a tiny tidal volume, because it's panting, for example, then if you give it a breath and the dead space is not excessive for its normal tidal volume, its rebreathing will reduce to zero in all likelihood. If the animal still has problems, then it might be that you have to change the breathing system because the respiratory resistance, particularly to inspiration on small animals, is too great and is causing rebreathing that way. It's suppressing the ability to generate a big enough tidal volume. If you then successfully stop rebreathing, you now assess your capnograph shape. So if your capnograph is not normal, often what you'll see is an obstructive pattern, which is basically the sawtooth where the alveolar plateau phase of the capnogram keeps rising, and it rises quite sharply. So you want to check for kinks in your breathing system, in your endotracheal tube, and you want to double check that your endotracheal tube is not too far in the patient and actually causing bronchial intubation, because that will cause only one part of the lung to be ventilated and the rest is just building up CO2. The other problem you might have is obstruction of the endotracheal tube, a partial one, so you're still able to breathe around it, but it is affecting expiration, and then you might suction the ET tube. If in doubt, you should probably consider reintubating and repositioning your ET tube, but you need to remember to uncuff your tube. If your capnograph shape is normal, then you should give another manual breath. And if the compliance is abnormal, you should consider whether or not there might be external compression of the chest. So is there a sandbag squishing the patient? Is there surgical equipment lying on somebody resting a hand on a tiny cat? But if the answer is no, then you should auscultate the chest. If you hear audible fluid sounds, that's often upper respiratory tract and you can suction the ET tube, or if you need to, you can re-intubate. If they're lower crackles, lower airway or pulmonary crackles, then there's not very much you can do, but you should probably then consider starting IPPV. If there is external compression of the chest, then that's easily solved. Remove it. If the auscultation is clear, then you should also start IPPV, because if there's no external compression, then the animal is basically hypoventilating with a normal capnograph shape, then IPPV is going to fix it. Particularly if the rebreathing bag and chest compliance squeeze when you give a breath feels normal. Hypocapnia I've lumped together with apnea, which of course are not the same thing, but I've considered them both in the same section because they often have similar reasons, causes. So equipment failure, once again, not to be forgotten. So patient disconnection and capnograph disconnection are probably some of the most common reasons for having perceived apnea on the capnogram. So the animal is actually breathing fine, but we're just not picking it up. Ventilation. So if you have respiratory arrest, obviously you're going to become apneic and there's going to be no CO2. And that is an emergency potentially, unless you've just injected some propofol and we're expecting that. And then hyperventilation, so the animal is panting because it's painful or has got inadequate depth of anesthesia. Then we've got reduced cardiac output, so hypotension. Remember what I was saying about the minute ventilation. If it stays the same, then the CO2 should only really change if your cardiac output changes, and therefore the carbon dioxide load getting to the lungs changes. And then low metabolic rate, so if the animal is really, really cold, it's not going to be producing the CO2. So we assess the patient depth again. If patient depth is inadequate, then we probably need to reduce the vaporizer setting, actually that should say, because we're going to get, we're probably going to be deep and therefore becoming increasingly hypotensive. The alternative is that you might have to increase the vaporizer setting because the animal might be breath holding or panting and therefore is hypocapnic and the depth is inadequate. So it could be either way. If your depth is adequate, however, then you need to assess your respiratory rate and pattern. If you're hyperventilating, then either that's because you've got inadequate depth of anesthesia and you need to recheck that and potentially increase your vaporizer setting. Or if we've got inadequate analgesia, we might be panting because we're painful. So if that's the case, then give additional analgesia. If you think you've got additional analgesia, you've just given it and your analgesia will be effective probably, then it's probably a case of starting IPPV to take control of the breathing pattern. If the animal is apneic, then clearly we're going to start IPPV, but we also need to take into consideration that this might be an emergency. So is this a respiratory arrest that's just preceding cardiac arrest? Does this patient have brainstem disease and therefore no drive to actually breathe? And then if it's an undesirable respiratory pattern, then we're starting the ventilator for, we might have to give midazolam or another benzodiazepine to basically relax the muscle so that we can actually perform the ventilation without the animal fighting against us. If the respiratory rate and pattern were acceptable, we go on to assess the blood pressure. If it was high, then we need to reconsider our analgesia again. If it was low, then we need to troubleshoot the hypotension. And then lastly, we're going to assess temperature. And if it's low, then that might be accounting for our low CO2. So we're going to troubleshoot that, and I'll get onto that later. Next is hypoxemia. So I'm going to draw the oxygen dissociation curve of hemoglobin for you. And on the y-axis, we've got the SpO2, which is the output of our pulse oximeter. And on the x-axis, we've got PO2, which is basically the amount of oxygen in blood. So this is our oxygen dissociation curve. It's sigmoid. That's important in a minute. We'll get onto that. So basically you can see that the top plateau corresponds to all the high percentages of SpO2, which means that there's not that much different in the oxygen content of blood between 100 and 96, for example. But then as soon as you get down the percentages of SpO2, you actually get a very steep drop in partial pressure of oxygen, the PO2. So you can see that as we're changing from red to pink to blue, in the background of the diagram, we're starting to get on the steeper part just after the plateau or before the plateau, depending on which way you look at the curve. So now our SpO2 is only dropping by a percentage, but actually that's corresponding to quite a big drop in the PO2. So, for example, if we look at an SpO2 of 90, that suddenly equates to a PO2 of around 60, which is much, much lower than our cutoff value of 80, which is already quite low for the PO2. And then we just have to remind ourselves that that's very bad for our cells and that our acid-base balance will be affected by it because we're going to start going into anaerobic metabolism. So there I've just reiterated the fact that a PaO2 of less than 60 or an SpO2 of less than 90 are really bad. So causes for hypoxemia are hypoventilation or apnea. That can again be drug-induced. It could be pleural space disease, and I've included pain here because not necessarily intraoperatively, but postoperatively, animals that have had a thoracotomy, for example, might be so painful that they actually hypoventilate because they're painful, and that will affect their oxygenation because, of course, they've also got pulmonary pathology as well, probably why we did the thoracotomy in the first place. Then there's impaired diffusion. So that's with lung disease really, so pulmonary pathology, but we can also have the iatrogenic side of that, so oxygen toxicity, particularly in people being ventilated with 100% oxygen for over 24 hours, shows signs of fibrosis, and that then actually impairs diffusion significantly. And then pneumonia and pulmonary edema as well. Then we move on to ventilation perfusion mismatch, which is the VQ. Which basically means that normally you would want to have all your alveoli equally perfused and ventilated throughout the lungs, but that's not the case, particularly because of the influence of gravity, but under anesthesia also because you have muscle relaxation and you have an altered fraction of inspired oxygen. So basically you will have alveoli that are very well ventilated, particularly if you give a manual breath, but that are quite poorly perfused, and then you've got alveoli that are very well perfused but poorly ventilated. And the idea is that you also have a certain amount of shunt fraction, which is basically the blood that goes via the lungs without being involved in gas exchange. And then true shunt fraction is things like septal defects, etc., where the blood actually never gets anywhere near the lung. So atelectasis in our anaesthetized patients is going to be the main issue, and that can be due to prolonged recumbency, so it's compression, physically just collapsing the airways, or it's high fraction of inspired oxygen, and that is rapidly absorbed compared to air, where there's a high nitrogen content, and that's termed absorption atelectasis. Then we have equipment issues. So we could have endotracheal tube or airway obstruction. Of course, the airway obstruction could also be a pathology, or like BOAS, for example, or we forgot to turn on the oxygen. And then we've got pharmacological, which I've repeated the drugs for. So hypoxemia troubleshooting. We want to check that our oxygen supply is on and connected to the patient. It's going to be the easiest and quickest thing to do. So if the answer is no, then fix it. If the answer is yes, you can look at the patient and see that it is breathing. You can look at the capnograph, the rebreathing bag, or the patient itself, depending on what you have access to. If the answer is no, then you troubleshoot apnea, as I've discussed before, and you start IPPV with 100% oxygen. If the patient is breathing, then you give a manual breath, and if the rebreathing bag feels normal when you squeeze it and the animal's chest excursion seems appropriate, then you can move on. But if not, then you probably need to consider whether or not to suction the endotracheal tube assess the tube length, and potentially re-intubate, which is what we've already described previously with ET tube obstruction. If the answer is yes, then you need to check your mucous membranes, whether or not they're cyanotic or pink. If they're cyanotic, you probably need to start IPPV with 100% oxygen. But bear in mind that we can only really detect cyanosis clinically by looking at mucous membranes when our SpO2 is less than 74 or thereabouts. And if they're pink, then we probably want to reposition our pulse ox, because actually the majority of the time the pulse ox is a culprit, and it is an equipment that is particularly prone to poor signal noise ratios because it has to deal with a very small pulsatile component of blood flow that it measures compared to all the other tissue that it has to transmit light through. But it's very important that you rule out the life-threatening complications first before you just blame the pulse ox and reposition it. Now onto the home stretch, which is the body temperature regulation. So if you're hypothermic or pyrexic, you increase the amount of heat, of course, that is generated in your body. So normally your body generates metabolic heat through processes in the liver and the GI tract in particular, so that's 60%. Your muscle at rest contributes about 25%, and your brain just converting glucose is about 15%. If you now add an inflammatory state where you've got lots of metabolic activity from inflammatory cells, or you've got malignant hypothermia, which is a ryanodine receptor related problem reacting to inhalational agents, and then you're also fuzzy and you're maybe covered in a blanket and you're going into an MRI, then you really become quite hot very quickly. So temperature over 39 degrees is usually what's quoted as being dangerous, or non-physiological, and the hotter it gets, the more dangerous it becomes. And the most important thing is to rule out life-threatening hypermetabolic states like malignant hypothermia, even though they're rare. So you check the capnograph. If the end-tidal CO2 is high or rapidly rising breath on breath, then you've got to assume this might be hypermetabolism, and then you discontinue inhalational anesthesia and ideally just recover the animal. If you have dantrolene, which I doubt you will have, because generally it's only human hospitals that will have it, because people also get malignant hypothermia, then you can give that. But otherwise, you're going to reduce the amount of warming. And that's also what you're going to do even if the animal doesn't have malignant hypothermia. So you're going to turn off your bear hugger, you're going to disconnect your electric heating mats and take off humidity and moisture exchanger. And then you're going to start some active cooling with cool crystalloids going IV, ice packs on the jugular which are clipped for better contact. Water or ethanol irrigation will work, or spraying on the pads. But it's important that if you use water, you also use a fan, because it's not actually that volatile, and it's the latent heat of vaporization which will cool the animal, and not the fact that you've got water on it. You can also increase the fresh gas flow in your breathing system, so particularly if you're on a circle, that's going to conserve quite a lot of heat normally, and the soda-lime reaction also causes heat, creates heat, so increasing the fresh gas flow, although it's not very economic, will help. Or you could change to a non-rebreathing system. And finally, you can consider pharmacological help. So we said before that acepromazine vasodilates and therefore will reduce the amount of heat retention, and you can use that to your advantage, but you should only use that in a cardiovascularly stable patient and be prepared for the blood pressure to go down a little bit. And then if you think it's pyrexic dog, you could give paracetamol as well. But it's really important that you keep monitoring your temperature, because it can easily go the other way. And once you've turned everything off, the animal might get cold. So hypothermia is going to be much more common under anesthesia. You've got a cold environment and you've got your anesthetic drugs. So your cold environment, you're basically going to lose a lot of heat through radiation, and that's the initial loss of heat that you get under anesthesia. And it's literally radiation waves of energy leaving the body. There is nothing that you can do about that. Then you have convection, which is basically like airflow, for example, moving over the animal's skin. And then there's conductive losses, which is basically the patient lying on a cold metal table, for example. Anesthesia itself will reduce your metabolic rate by slowing everything down. It also causes muscle relaxation or paralysis, so you can't warm up with shivering. It causes CNS depression, and you're also giving cool IV fluids. So the net effect is going to be to basically reduce the smoldering fire. Well, reduce the fire to something smoldering. So hypothermia, why do we really care? So I've put up some cutoffs that I consider moderate, severe, and life-threatening hypothermia, but obviously they change for different animals. In people, the reason why we've got quite a lot of data on it is because people do turn up to hospital hypothermic quite often, and they also use a therapeutic hypothermia in people. So there's a lot of data in it. Basically, in people, if you're under 35 degrees centigrade body temperature and you're undergoing a major surgery, then you're much more likely to get myocardial ischemia and therefore arrhythmias. So it's going to have an effect on blood pressure. If you're 1 degree under normal body temperature, you have 16% increase in blood loss because you're less likely to clot and there's platelet dysfunction, which is important because you're much more likely to require a blood transfusion if you're already undergoing a high risk case. If you're 2 degrees under normal body temperature, you have a 3 times higher risk of wound infection. And so that also relates to how long the anesthetic is, of course, because you're much more likely to get cold the longer the anesthetic wears on. And then you get something called cold diuresis, where you get a reduction in antidiuretic hormone production, which can massively increase your urine output and if you're really cold, and that will of course affect your whole body water status, and if you become really dehydrated, that can make you hypovolemic too. It also delays your recovery because you've got a significant drop in metabolic rate and therefore in drug metabolism, and because it increases the solubility of volatile anesthetics in blood, they're less likely to be breathed off as well. So both injectable and inhalational agents will have a prolonged effect. So the little rabbit was just to remind me that you don't want to immediately recover a severely hypothermic patient because rapidly warming is also not good. So the textbooks recommend 0.5 to 2 degrees centigrade per hour if the animal had life-threatening hypothermia. And it's worth bearing in mind that the active warming that I'm going to outline in a minute can achieve 1 to 3 degrees centigrade per hour, so might be too fast if you put all the warming on at the same time. So warming strategies include prevention is cure, which is true for most things, I guess. So if you pre-warm the animal, then that can help, particularly if it's going to be going into a cold environment like ultrasound, CT, MRI. You can increase the ambient temperature, that's particularly used in operating theatres. You can minimize the amount of skin exposure with the clip and the prepped area, and you can avoid using really high ethanol preps, which are very volatile and therefore take a lot of the latent heat of vaporization off the animal, so cool it very quickly. And then you should employ as a routine passive insulation, so don't put the animal straight on the cold metal table, cover it with a blanket, cover its pores, in particular with bubble wrap, for example, that can help. Use forced air warming of the core, so that the thorax, abdomen, etc. Use humidity and moisture exchangers to try and reduce the heat loss through the airway, although there's also an indication that what drugs you use will affect this significantly as well, so using a HME may not be any more effective than using, say, medetomidine over acepromazine for a prolonged imaging procedure such as MRI. And then using low-flow anesthesia in a circle system will really help because, as I say, the soda lime reaction creates some heat, and the low flow means that you've got less dry, cold gases going into your respiratory system from the anesthetic machine. And then for the animal that's cold and is undergoing exploratory laparotomy, you can use peritoneal lavage with warm saline. And if you're really desperate, you can lavage the bladder with warm water or would do a warm water enema. So we made it. In summary, don't panic. Try and rule out the things that are life-threatening and therefore need actioning very quickly, and also the ruling out easy to rule out things such as disconnection of the patient from the breathing system. Trying to give a breath, you'll soon notice that the animal is not connected, even if it's under miles of drapes. Use a methodical approach, so try and do your troubleshooting in the way that you would do a clinical assessment of a patient. And you could use the same approach every time, for example, going from anesthetic machine to patient and back again, and you'll probably come across the issue. And remember to communicate with your team members because they might not be paying attention to what you're doing. They might be doing their own jobs. But if you ask them, they might well have some good input and also they probably need to know about what's going wrong anyway, so that they can stop what they're doing potentially. Then use your anesthetic chart. The fact that you're recording data over time will give you an indication of what the trends are and whether or not intervention is required, and how quickly that intervention is needed. So I hope that was a little bit helpful. Feel free to send me questions on info@hamiltonsspecialist.vet, as indicated at the bottom, just below. And I'll be back with some more CPD as the coronavirus quarantines and things continue. Thank you for listening.